Okay, so I am delighted to have this opportunity to provide the opening address this Friday morning and to speak specifically to the conference theme. The conference theme is culturally appropriate research, practice, and policy approaches to health disparities within a stress and coping biopsychosocial environmental cultural framework. So I'm going to, as you can see, have a presentation with 6 parts. And so we'll start with noting what we're celebrating today. We'll talk specifically about culturally appropriate research, practice, training, and policy, providing the CHEUSE, the new Center for Health Equity and Urban Science Education as an example. And then we will go on to talk about approaches to health disparities within a stress and coping framework. We'll then turn to the topic of brief training for practice, becoming culturally competent and culturally appropriate. Of course, in the order in which I reverse them, note that. And then we're going to talk about culturally appropriate research and policy. And then finally, the biopsychosocial environmental cultural framework. So why are we here? Why is this conference a celebration? It is a celebration because we are launching the new CHEUSE, or we're going to pronounce it quite often CHEUSE, because we're going to ask you to choose health and hip-hop. And so we're launching it specifically at 10:30 this morning, so it will be born on the Ides of March. I don't know what the rising sign is, but it will be a Pisces center. And secondly, for the 5, we are celebrating the 5th annual Health Disparities Conference here at Teachers College. And it was quite an effort to put on this revival, and so we really have to express gratitude just for a moment to all of the volunteers, many of whom were here nearly all night so that you could have that beautiful badge around your neck. Of course, there's things that we wish we had time to do, like arrows in the hallway, so please be patient with us, and we apologize for the imperfection, but at the same time, I must really express my deepest gratitude, and of course, it has entered into love for my many doctoral students who have been so dedicated to this effort. And then for the 10, we're celebrating 10 years of the research group on disparities in health. I had actually traveled to Africa around the new millennium, and I discovered that there was something called an African technology using group and communal approaches. And so when I began to have a communal research seminar, also sharing meals, also having a temporary 2-day community as in this conference, you can see that the results were quite extraordinary. For the 12-year period before I started the research group, I had graduated 21 students. Among them, there were 2 African-American women. After I started the research group on disparities in health in 2003 and used this African technology of a cooperative communal group approach, I will have, by this May, graduated 82 very diverse graduate students with doctorates in health education. So why don't we have those of you who are members of the research group, who are alumni, why don't you just take a moment to stand up or wave your arms in the air? Come on, Sharon, come on, Dr. Tete, come on, just stand up. You are here, Dr. Nicole Hollingsworth, Harris Hollingsworth, a number of you, yes. And of course, the majority are working registration, or, thank God, they have jobs. And then the 125, we're celebrating the 125th anniversary of Teachers College Columbia University. And it's particularly meaningful for this conference to acknowledge that anniversary, given that the college actually had its earliest roots working with the poor immigrants in New York City and working to address the health inequities and education inequities that they were dealing with at that time. And so let's go in the right direction. Which way would that be? Okay, that one. Okay, so let's start with the first theme. So you can see that given the conference theme, I'm addressing the very first component. I am basically deconstructing the theme and focusing on culturally appropriate research practice, and I've added training because as it turns out, the Center for Health Equity and Urban Science Education is certainly very much about training. And so this is an image that I created because part of what we need to recognize is that even though we call this the 5th Annual Health Disparities Conference, the reality is that there really has been a shift, a global shift, toward speaking about what we want. We don't really want health disparities, do we? We want health equity. And so the idea that in all aspects of our lives, we need to create an individual and a collective and a communal consciousness where we're focused on what we want. What is our intention across these 2 days? What is it that we're calling forth? Professor Bash this afternoon is going to put forth a very powerful call that's going to have to do with focusing specifically on health, on school health, the way in which the academic achievement gap may be closed by actually focusing on 7 areas in particular where urban youth are coping with various health issues. And so what we also discover is that one of the most powerful things we can do in putting out a call is to say, I am. And so all of my students, before their exams, before their oral defenses, they are saying, I am calm, centered, and balanced. When they sit down to write, they are saying, I am calm, clear, focused, and ready to write. And so what is it that you may be calling forth, but we are now a 2-day temporary community, but we may actually be enduring, and that we are also a community by virtue of ever-expanding social networks, including those who are witnessing and thereby participating in the webcast, particularly when they send in their questions by Twitter. And so what are we taking action for? I'd like to suggest that we are taking action as part of a global social movement for equal access to opportunity for all. And further, we can now focus on the symbol for the CHEUSE, the Center for Health Equity and Urban Education. And so we're very much about a social justice mission. And so the idea is that if we focus on equal access to the opportunity of quality education, and of course, those of us in New York City, well, it's happening in Philadelphia too. So guess what? You're part of a global community experiencing school closures. We're in places where you may not even imagine that they are occurring. But the idea is we are very concerned about what's going to happen when class size becomes 40 or 45. We're very concerned about when schools that have been closed become charter schools. And there's a selective process or a lottery that locks many students out. But the idea is that what's critical is equal access to the opportunity of quality education. So Professor Christopher Emden and I are sharing a vision, and we're working toward the goal of a quality education by virtue, perhaps, of multimedia technology as well, that youth create, that how might a quality education that we collectively create and invest in lead to quality income and quality housing, and therefore quality in terms of the built environment. And the idea is that these are factors that can lead to equity and health for all. And so there is a website, and part of what you'll see on the website is even right there on the homepage, a discussion about building an online global community and movement for equity and justice for all. Again, social justice, equal access, quality education, all the things I just mentioned. But now to elaborate on what we mean by the built environment. The built environment includes access to nutritious foods. When we're talking about food deserts, gardens, parks, space for physical activity, daycare, healthcare, transportation, all of these are key ingredients. And we're going to see that policy today needs to include health. Policy in all areas needs to include health as a goal. And so the brief motto, choose health and hip hop, reflects the longer coda, a center focusing on health and hip hop to advance multimedia health and urban science education, to foster health equity and academic achievement as a global pipeline, preparing, thereby training, youth and professionals for careers in science, technology, engineering, mathematics, and the health sciences. within the 21st century movement for justice. Further, we can now turn to the second theme in terms of approaches to health disparities and coping framework. And so what is it that we mean here as we deconstruct the conference theme? Here we are talking about, and we can use the example of the new CHEUSE Center. Here we're talking about the importance of focusing on stress and coping, that there is stress in every domain of the biopsychosocial, environmental, cultural context. There's stress in the environmental context when we have diesel fumes as trucks are going through Washington Heights to get to the George Washington Bridge, that there is stress upon the biological system, that there may be stress in psychosocial environments where there is overcrowded housing or dilapidated housing. There is also stress in environmental cultural context. And so we can ask the question, what can enhance coping with stress? And we're going to find that one of the things that can enhance coping with stress is hip-hop as adaptive coping. To the extent to which youth can tap into a creative genius, the extent to which they are engaging in storytelling, tapping into also the oral tradition that is very much about the griot, for example, in African culture, and also building self-esteem and power. And so we're going to conceptualize hip-hop as one strategy for achieving adaptive coping with stress. And then we can also talk about an example. Where's the evidence? Where is the evidence? Are we proposing an evidence-based approach? And we're going to talk about the way in which we need an expanded concept of evidence. We're not talking about merely the randomized clinical trial, the RCT, what's held up as the gold standard in social and behavioral sciences. One of our former professors, Stephen Lepore, who left us to go to Drexel, his edited book in 2002, The Writing Cure, How Expressive Writing Promotes Health and Emotional Well-Being. And so if we think about the way in which our youth are writing their raps, to what extent do we find that this book provides groundbreaking research on the cognitive, emotional, and biological pathways through which disclosure, you're disclosing what's going on in your neighborhood, you're disclosing what's going on among your peers. Expressive writing and this disclosure influences mental and physical health. And they provide numerous examples of how expressive writing can improve the immune system and lung function and diminish psychological distress and also enhance relationships and social role functioning. This is enhanced coping. And so in 2008, as a part of what was an outgrowth of the 2000 Health Disparities Conference, where that Friday by 4 o'clock, we had secured a contract for an edited volume, and so toward equity in health. And so again, this is where I reminded you, we speak of what we want. And so we are moving this health disparities discourse toward a health equity discourse. And we're also moving from a discussion of stress to adaptive coping. And so the subtitle for this book, Toward Equity in Health, is a new global approach to health disparities. And the symbol for this movement from health inequity to equity in health is also the symbol of the Research Group on Disparities in Health. And we're delighted that the Research Group on Disparities in Health now has a home within the Center for Health Equity and Urban Science Education. And so to move from inequity in health to equity in health is certainly adaptive coping. And to foster a 21st century global civil rights movement for equity in health for all is certainly adaptive coping as well. And so we can also note that part of what was embedded in that prior symbol were these symbols of A over B. Imagine any agent, any actor A, and any actor B. And so we can think of all of the examples of where the person in position A presumes themselves to be superior and presumes the person in position B to be inferior. And clearly the goal is to move from that kind of maladaptive approach to what is adaptive. And so we can say that entire societies, systems, school systems, all kinds of systems that reflect domination, hierarchical domination, symbolized by A over B, they don't work very well. Yet we're seeking what's much more adaptive in terms of this non-hierarchical equality. And so that's what this shifting to a new paradigm is all about. The old paradigm to the new paradigm, from domination to non-hierarchical equality, from presumed superior and a presumed inferior to equality. And there are 13 forces that are driving this adaptive coping in this time, in this era. And so let's talk briefly about what these 13 forces are. We can recognize that there is actually in the literature, in the research literature, in scholarship, in community-based movements, a drive for this major paradigm shift. Who would like to continue in the old paradigm, where many in this room would be presumed inferior? Let's take a vote. The drive for new models of healthcare and training, the drive for new theories, perspectives, and identities, the idea being that we literally have been brainwashed by many of the theories that we have learned in the social and behavioral sciences. It becomes a way of thinking, it becomes an identity, and so we actually end up needing not only new identities, new perspectives, new theories, but we also have this drive for evidence-based approaches, and we're going to see, again, we're going to define evidence broadly, that there's a drive for transdisciplinary teams and community-based participatory research, that if you did not know, the National Institutes of Health basically has a new institute. It is the National Institute on Minority Health and Health Disparities. And we can talk about the leadership of Dr. Ruffin, who is basically ensuring that communities are competing for grants that are going to have a community-based participatory research focus, and that there also is a formula that's going to allow those from historically black colleges and universities to compete more effectively by virtue of a formula. And so there's a drive for globalization and global collaboration, but in this context, it is about cooperation and sharing. If there is a disaster in one part of the country, how quickly can we get resources to the part of the country, the part of the world, the part of our global community that has just experienced a disaster, extreme weather? The drive for cultural competence and cultural appropriateness we'll talk about. The drive for health literacy and linguistic appropriateness is very obvious. The drive to ensure the right to health. The idea that there basically have been declarations and countries have endorsed the concept that there is indeed the right to health, the drive for social justice and acknowledgement of forces in the social context. And so that's very much, we also talk today about social determinants of health. And so we have the Commission on the Social Determinants of Health that was formed in 2005 that is working through the world, through countries, through committees, to help governments and community-based movements to really acknowledge and address the social determinants, the social forces in the social context. The drive to protect and support the most vulnerable. We have a symbol in the conference program with the heart shape. The idea being that those are really some of the most vulnerable populations impacted most severely by disparities in health. There is a drive to repair damage, restore trust, and take responsibility, particularly in the aftermath of experience such as the U.S. Health Services Tuskegee experiment. Well, you know, we know it as Tuskegee, but it's really should be appropriately referenced in terms of the government initiative. And this is what is really the most refreshing of all. The drive to redistribute wealth and access to opportunity, where there actually is discussion about the need to basically ensure that resources in terms of wealth are more equitably distributed. And then there is the brief training for practice, becoming culturally appropriate and culturally competent. And so let's go through this. The idea that to shift the paradigm to one of non-hierarchical equality is to achieve culturally appropriateness to the extent that a description for content, research, or interventions, this is what we can think of when we say this research design is culturally appropriate. This intervention is culturally appropriate. Hip-hop is culturally appropriate to the extent that it reflects an appreciation of the cultural background and history of the consumers, research subjects, or clients being designed in accordance with the characteristics and needs of the target audience or population. It's based on prior information or experiences as well. And so we can also consider a brief approach to cultural competence training that's rooted in the notion of achieving adaptive responses to diversity and difference, regardless of what that difference may be. And so in this 2005 book, Making Mandated Addiction Treatment Work, where we are recognizing the mass incarceration crisis, basically the way in which DEA agents, drug enforcement agency agents across the country had been trained in stop and frisk procedures, where you may stop 300 people and you may search them and you may only find 3 hits, 3 out of 100, where someone actually has in their pocket an illegal substance. Or they have, in New York City, cannabis in their pocket. It's not illegal to have it in your pocket, but when the police say, "What's in your pocket? Show me what's in your pocket," when you pull it out, it is now a criminal act that it has been exposed, that they basically asked you to engage in. And so as a result of the need to make those incarcerated, those on parole, probation, or mandated to addiction treatment work, we certainly needed to provide a brief training, at the very least, in cultural competence. And so here we make it so simple. You know, we have to learn a new set of ABCs, a new set of affective responses. How are we feeling? Okay, ideally we're feeling respect, empathy, acceptance for those who are diverse and different. Behavioral responses, we'll see examples of those. Our cognitive responses, we need to make sure they are adaptive, that they work as opposed to maladaptive and not working. And then there is, within our identity development, we have to learn to discern our own adaptive versus maladaptive responses. I like to say that we literally have to catch ourselves in the act of projecting a negative and low expectation, of basically delivering a stereotype, thinking a stereotype, acting on the basis of a stereotype. That it's our responsibility to develop the capacity to self-observe, to self-monitor, and to stop and replace those responses that are maladaptive with those that are adaptive. Cognitions that are appropriate. Different does not mean wrong. Different does not mean inferior. Adaptive, affective coping. I like to ask, well, who are we? Okay, we're learning a new set of ABCs, but who are we? And so R is reminding us of what adaptive affective coping is. That in working in Harlem with the chemically dependent, if there's anything that you must convey, it is respect in order to engage anyone in any kind of meaningful intervention. And acceptance and empathy. Certainly there's a large body of literature that talks about the importance of genuine empathy in terms of outcomes for treatment. And so part of what I talk about is that at the very least, people want to be respected. And yet is yet a higher order experience to be genuinely accepted. But forget about the goal of tolerance. We are beyond that. We're talking about, I don't want to be tolerated. Well, if you really have an issue, at very least tolerate me and be civil. But that's not the goal within anything that we conceive of as cultural competence training. We have to have a higher standard. The higher standard is respect, reciprocal recognition. All that the invisible man wanted in Ralph Ellison's book. Not to be invisible. But ideally, we go a step further, and someone has the experience of genuine acceptance. And certainly, what's maladaptive in terms of behavior would be behaviors such as discrimination. It's a maladaptive behavioral coping response to diversity. And so this is where we can talk about all of those conditioned responses, the ABCs that are maladaptive. For example, the cognition, the thought that is equal to stigmatization, stereotyping, maladaptive, disdain. Okay, I mean, we talk about, why is it that someone isn't going for screening? what is it that someone did not return for their screening test result? To what extent are there these feelings in the room? Bad vibes. But to what extent are actually some of us experiencing disdain? And behaviorally, there is discrimination as a maladaptive. And so the idea is that we can actually talk about what happens in service delivery. How do we end up having disparities in service delivery? And one way is when there is deviation from some standard of care. Okay, did you ever, in the doctor's office, you're like, well, how come I didn't get put on the treadmill? Or how come I didn't get that test order that everybody at work was talking about? To what extent did someone see, for example, a black woman and presume that I probably had, Medicaid, where I may be walking around with, the very nicest, most elaborate insurance plan that would pay for, a full body MRI or any set of tests. But to the extent that I discriminate because I deviate from some standard of care. And so one of the things in a 2012 Institute of Medicine report that we see is how important it is, for example, in emergency rooms, intensive care units, to actually use checklists and to authorize nurses to stop doctors when there is deviation from the standard of care as embodied in that checklist, and that this kind of approach actually is reducing negative health outcomes. And so in terms of our adaptive effective responses, I've talked about that acceptance, respect, and empathy, but we can also recognize that we also have to accept that there is a process that our colleagues go through, that our students go through, that professionals go through, meaning that there are actually stages of change. It's a process to change. If we have been brainwashed and socially conditioned through the media, through television, through sitting at dinner, and hearing our families talk in a denigrating way about some other racial, ethnic, or religious group, that we have been systematically brainwashed. We have socially conditioned cognitions. And so now the goal becomes one of having to move through stages of change where we may have to accept and empathize with those among us who aren't even thinking about these issues. They're in pre-contemplation, or they are thinking. There may be some here or in our webcast audience who, at this very moment, never really thought about some of these issues, but now they are thinking about them. They're thinking about an intervention that they did with someone in a hospital or a clinic. They're thinking about an interaction with a student in their office, where maybe they did feel disdain. And so the idea is that they're thinking, they're in a contemplation stage, or they are in a preparation stage. They have made a decision by tomorrow, end of conference, that no, they are prepared to do some additional work in the area of cultural competence training. Or they are actually taking action to change, or they are maintaining change. And so action, making change for less than 6 months, maintenance. You've been doing this for more than 6 months, perhaps a couple of years, perhaps a decade. And so certainly we recognize that when we are in various situations, we may sense those who are bringing a cultural level of competence that suggests that this is something that they have been doing for many years. And certainly we also may recognize those who haven't even thought about these issues. But what are we to do? We are to do the same thing that we already mentioned with regard to our clients, my clients, that I dealt with in the context of chemical dependency consultation work, doing, very elaborate assessments, doing super long reports so that individuals would qualify successfully for Social Security disability. And so acceptance, respect, that I have to accept those in pre-contemplation and contemplation, those who aren't thinking about these issues, okay? It's not to get angry. It's not to get so angry that our colleagues or our students or our neighbors are not even thinking about these issues, to get so angry that we are actually damaging our own internal organs, that we are basically having the release of adrenaline, that we are basically in a state of hyperarousal, and so we have to learn how to let it go. Looks like another TKO. I think I better let it go, I was walking down the road, I saw a toad. I said, I think I better let it go, because, maybe I didn't remember the words. But the point is that there's also a drive for new theories, perspectives, and identities. And so when I go through these stages of change, I am actually creating a new identity. I'm going through stages of identity development. And so I am achieving a progressively more mature identity. As someone executing adaptive responses to diversity, I'm learning to observe myself and to catch myself in the act of deploying some maladaptive response. Okay? I am actually stopping and interrupting these maladaptive responses, and then I'm replacing them with those responses that are adaptive. I'm learning to focus on strengths. I may be frustrated that someone has arrived in my office late, intoxicated. I am focusing on strengths. I am focusing on optimistic thinking, respect, acceptance. I am not deviating from the standard of care. I'm going to ask all the assessment questions. I'm going to adhere to the standard, the evidence-based standard, so that there is no discrimination in service delivery. And that these are the kind of adaptive responses that we have to engage in that become increasingly refined. I rode my bicycle, I fell, I was 5. I rode my bicycle, I was smooth, I was 8. Okay. And so this is our goal. And so what is at the core of this is the concept of adaptive behavioral coping, that we can actually deploy an evidence-based approach, literally selecting. The goal is that, you go to a restaurant and there's a menu. Okay, here's the chicken menu, the fish menu, the burger menu, the pizza menu. So this is the menu of evidence-based approaches. And this is where we are evolving as a field of health disparity research and practice and policy, and that we are to adhere to standards of care that are evidence-based, standard protocols, checklists, as in intensive care units. And now the fourth area, toward culturally appropriate research and policy. And so now we're going to deconstruct that part of the theme, focusing on culturally appropriate research and policy. And so part of what we hear, for example, through the work of Buchanan and Allegrante, in a chapter that they contributed to the edited volume Toward Equity in Health, A New Global Approach to Health Disparities, is this very nice discussion about demands for scientific rigor. This is where we can talk about what constitutes evidence. Are we talking about the randomized clinical trial, the RCT, the gold standard in social behavioral research, where basically psychology, the social sciences have modeled themselves not after epidemiology, but after medicine and the biological sciences? If you were going to a physician, you may be very pleased to know that the physician is recommending a pill for you, unless, of course, you're into terms of medicine, but that there was a randomized clinical trial, that there was a placebo, and that there was evidence that the physician just isn't, it might work. I don't know, let's just try it. You'd like to know that there is some confidence, but the idea is, when we're talking about behavior, and we're talking about multiple problems behavior, we're talking about someone who perhaps did, at age 18, get stopped and frisked, had a very small amount of personal marijuana on their person, but that once they are engaged, it turns out that they are in pre-contemplation. They're not even thinking about stopping their cannabis use. Perhaps they are in contemplation about their cigarette smoking. Perhaps they are in preparation with regard to perhaps some violence that they have engaged in because they really do not want to get charged with a felony assault again. In other words, there might be multiple problems. There might be perhaps a diagnosis of manic depression and a need to begin to adhere to a psychiatric medication regime. But the idea is that we have these biases that tell us that what's really going to be evidence is not going to be focus group or qualitative or interview data or community-based participatory research data. There's a bias that the kind of research that really has rigor is going to focus on the individual, likely focus on just one problem behavior that they have, Oh, and in addition, that they want to do an experiment, randomly assign them, and that it would be a randomized clinical trial. But as Buchanan and Allegranti point out, there is actually a demand for distributive justice because this bias, this focus on the individual behavior change, and scientific rigor could actually be one of the reasons that we have had a lack of progress on eliminating health disparities. So this is a really refreshing view. So they expand on this notion that randomized clinical trials that focus on individual behavior often also want to have the goal of controlling behavior versus demands for distributive justice. That these are your tax dollars. There should be some fair and equitable distribution. There should also be respect for the community right to engage in self-determination, not that the problem of interest for the scientifically rigorous approach focused on individual behavior comes from the RFA, from the announcement, but that through community-based participatory research, it's the community that identifies their concerns from the very beginning. And so this is where we have a new NIH center that's very much focused on community-based participatory research. We have those who've been advocating for community intervention research, where we value our interviews and our focus groups with key stakeholders, key informants, surveys, community forums. And we're actually going to have a community forum here tomorrow for 55 minutes where we're going to have a discussion about how can we focus on health in hip-hop culture. To what extent do we need to bring out into the open some of the mental health and physical health issues that we see in hip-hop culture, but that could be better addressed? And so another development, now we can talk about policy. In terms of policy, part of what Lahiri and Pulligan do is that they look at New York State level data, and they look at self-assessments of health by various racial ethnic groups. And their premise is that individuals should have the same opportunity to achieve their potential health levels as a first principle of justice. And so to summarize their major finding, they end up concluding that what really is needed is not only jobs, but an income redistribution policy. So this is where we're going in this field, where we see these very elaborate analyses with these very large statewide national data sets, and what are they increasingly concluding? That we need a policy of income redistribution, plus employment opportunities, plus educational access, and that is how we're going to begin to eliminate health disparities. So for those of you who may be used to that scientific, rigorously conducted research focused on comparing groups of individuals, and typically, the Black or the Hispanic group did so much worse on some health outcome than the white group, et cetera, and we just feel, oh, this is depressing, another study, the idea is that it's time to move toward intervention research, that we're moving into really a third generation of health disparities research, and this is what it's doing. It's focused on policy, it's focused on the need for there to be government level, state level, local level changes that involve income redistribution and prioritizing employment, educational access. That's what's going to do it. Yet we see schools closing and class size increasing. And so their major factors that Lahiri and Peligan found were household income, employment status, and education. Those were the factors generating the disparities between minority groups and the white population. And now we have the Institute of Medicine releasing a 2012 report. And what are they saying that the new direction in policy that is needed? What is that new direction? It involves paying attention to the social determinants of health, and that this involves a very broad definition of health policy. That health policy means focusing on housing, focusing on employment, community development, income support, transportation, environmental policies. And one of the challenges is how do you get the housing authority to communicate with the transportation authority to collaborate, and how you create a built environment that has all that's needed to sustain physical activity, as well as eating what's on my plate. How are we supposed to follow Michelle Obama's plan for the country. If we do not have a built environment that can support physical activity, parks, gardens, fresh vegetables, locally grown fruits and vegetables. And this is also a comprehensive view of policy. It translates into consideration of the vital role of where people live, work, worship, and play, to quote Dr. David Williams from Harvard. And the Institute of Medicine report also talks about, for example, through the testimony of Ms. Thompson, looking at childhood obesity and the nationwide movement, this is a perfect example of someone saying it is time to move beyond a focus on individual behavior because it will not work. Again, that scientifically rigorous focus, clinical, randomized clinical trial, individual level. The idea is that instead of this individual behavior approach, we need complex changes. We need to focus on where people live, where they work, and in creating those healthy environments that encompass the food environment, food deserts, the physical environment, parks, as well as the educational environment, class size, access to quality education. And so there is this concept of having health in all policies. And so in the same testimony in the Institute of Medicine report, Dr. Wolf aptly summarized in converging with this view that this is a movement we're talking about here in this conference, having a social justice, a global movement. Dr. Wolf is saying there is a movement toward health in all policies. So as a temporary two-day community that may endure through social networking, we need to realize that this is the cutting edge in health disparity research, figuring out how we can indeed focus on health in all policies ranging from transportation to housing, and that this is a broad, comprehensive policy approach, and this is what people believe is actually going to lead to the elimination of health disparities. And guess what? It's yet another major paradigm shift. And then we can look at the biopsychosocial environmental cultural framework, and I deconstructed by highlighted in green in the PowerPoint. And so as early as 1991 in my book called Crack Cocaine, I introduced a biopsychosocial model, as some others also had. And so now we're talking about the biopsychosocial environmental cultural framework. It is integrated. It forces us to integrate theory. We're going to see in many of the speakers at this conference that it's about if you are going to address multiple factors, you need theories that are multifaceted, that integrate a number of components and theories and perspectives. And so the idea is that this established biopsychosocial approach tells us that there are domains. What's happening in each domain? The biological domain. What is the impact of stress on biological homeostasis, on hormones that may be released when we are under stress? I'm getting angry. Oh, I'm at a meeting, and I just make a recommendation, and then a white male makes the same recommendation. It's, oh, what a great idea. Okay? Okay, so what am I to do? I am calm, centered, and balanced. I am calm, centered. Why? I think I better let it go. I was walking down the road, I saw the toad, I think I better let it go. Why? Because it actually ends up being a very selfish act to preserve my immune system functioning, my cardiac functioning, my biological stress reaction. I need to observe myself, engaging in a maladaptive response, catch myself in the act. I then need to stop and interrupt that response that's maladaptive. I then need to direct myself to execute an adaptive coping response. I accept and respect and empathize with that person who's not even thinking about cultural competence. I am calm, centered, and balanced. I accept that maintaining my employment in this institution may mean that I get a monthly paycheck if I can accept and respect and empathize with those who are in pre-contemplation and not even thinking about these issues. And that until I have tenure, I might not say a word. But then I discovered that the most powerful thing to do is to ask a question. And you can ask the kind of question that makes it clear that someone needs to move from pre-contemplation to contemplation. And your question may be the stimulus for that. As you say, it's taken a long time. How long do we have to wait? I am calm, centered, and balanced. And so all stress impacts biology and health status. Adaptive coping protects your biological functioning and maintains homeostasis. Maladaptive coping leads to loss of homeostasis and damages health. And so in terms of this psychological domain, part of what I did in a 1996 book, Adult Children Dysfunctional Families, bad title, it should have been the subtitle, Prevention, Intervention, and Treatment for Community Mental Health Promotion, integrated 4 psychoanalytic theories, integrated cognitive and behavioral theory, showed how they were basically talking about the same elephant in the room, but integrated them to see the whole elephant. But the whole point is that it really came down to self-regulation. Self-regulation of your affects or your impulses, okay? I have an impulse to pick up my laptop and hit this person beside their head if they say that statement one more time that reflects pre-contemplation for cultural competence. But I'm going to regulate my aggressive impulse. I'm going to regulate my affects. I am calm, centered, and balanced. I'm going to regulate my self-esteem. I got the power. Don't. Okay, I'm going to regulate my self-care behavior. Excuse me, I'll be right back. I think this is going to be a 10-minute bathroom break because I'm going to sit here and say I am calm, centered, and balanced until this meeting is over. Okay? And then psychosocial, self-regulation of all your psychological responses occur in a social context. Okay? Social determinants, perceived racism, medical mistrust. One of Dr. Kathleen O'Connell's students is actually going to present on her findings tomorrow because the government decided that they weren't going to pay for travel for 2 of our participants. That's where we are. But in any event, the psychological domain also goes back to this image because it goes back to a 2003 chapter in an edited book I did with Robert Carter in 2003 on a multicultural approach to violence, where I talked about invisible covert, visible violence, defined our cultural violence, defined violence, but most importantly, offered a psychology of oppression. And so that's what this A over B is. It's an entire psychology of oppression based in integrated theory. And then the symbol A equals B is really a psychology of, liberation. Ooh, see? Look at that maladaptive response. Okay, it's supposed to be the psychology of liberation and identity development. And in terms of this environmental cultural context, everything occurring in the environment, culture, our history. In this 2003 chapter, I talked about the trauma of Native Americans walking the Trail of Tears, African Americans engaged by force in various acts on plantations, and also other groups, people with disabilities who have experienced disdain and disregard, et cetera, et cetera. And so we find support for this comprehensive biopsychosocial environmental cultural framework. Ogie Degby talks about the 2002 Institute of Medicine report on unequal treatment. And basically, they identified 3 levels that we need to pay attention to: patient-level factors, provider or physician-level factors, healthcare system factors, and that interventions are only going to be meaningful if they are looking at underlying mechanisms. And so there is support for this focus on underlying mechanisms and also taking a multifaceted approach, because in this Institute of Medicine report, Dr. Paula Braveman called for more intervention research, not the focus on the individual, not the randomized clinical trial, not engaging in the silver bullet trap. She says avoid the silver bullet trap, the expectation that a single intervention will be enough, when indeed multifaceted interventions are needed involving a multifaceted approach. If we have the roots of health disparities are multiple, as this biopsychosocial environmental cultural model forces us to appreciate, then the implication is that funding institutions and policymakers will have to be convinced that such research focusing on multiple factors, on multiple levels, patient level, provider level, system level, it's necessary. She says it may be messy and complex. But, I don't know, it seems like when certain people do things, it's clean. And then when other people do things, it's dirty. So she calls it, it's not particularly clean research. But the point is that I am calm, centered, and balanced. I'm not presuming. But to focus on these mechanisms is a comprehensive approach, as we see in the biopsychosocial approach. And there's more evidence about social environmental factors. We can go to the work of Mindy Fullilove, who has a new book that's going to be coming out soon. But the whole point is that she focuses on how displacement from various policies has exacerbated and led to health disparities. And so that I end on time, I will just say that hopefully you can consider this stress and coping biopsychosocial environmental framework and find that it assists you in your personal transformation in this global movement for social justice and access to equal opportunity for all.